Hello, everyone, and welcome to our webinar today, where we will be presenting to you our research on non-opiate substance use and minority ethnic communities. Welcome to our session. My name is Priya. I am a NatCen research associate, and I was lead for this specific project. We are delighted to have you join us today. We're really happy to have the opportunity to share with you our research findings from this project. It was an 18-month project and it really was a labor of love. So thank you for coming to join us, hear about it, talk about it. I have with me the project team today, and I am also ably supported by the NatCen communications team as well. So we hope that you're able to enjoy the session without any trouble or technical difficulty. Just to let you know, the running order of the session is as follows. Essentially, we have a presentation for you that will last around 35 to 40 minutes, where we'll really do a deep dive into our project and our findings and recommendations that come off the back of it. Thereafter, we have some time for question and answer. So you are free at any time during the webinar session, to post your questions into the chat. And then at the end of our presentation, we will do our very best to work through some of the most popular questions that are coming up in the chat, so that we can engage with you through that channel. The webinar will be available on the NatCen YouTube channel after the session as well. So without further ado, I think we will get started on the presentation. Thank you, Crescenzo. So first of all, I would like to, before I talk to you about what the research aims were for this specific project, we would just like to say that we are incredibly grateful to the Department for Health and Social Care, the NIHR, and the London School of Hygiene and Tropical Medicine for funding our project and for supporting us all the way through our project. Without them, it would not have been possible to do this work. So we are incredibly grateful to our funders. The project had a number of aims, and it's one of the first projects in many years to actually explore these aims and these issues, specifically for minority ethnic communities, in, as I say, a number of years, and to do it using a number of different data sources and methodological triangulation. We'll talk to you a little bit more about what we covered in our study shortly in terms of the various strands and the methodologies we used. But essentially, our research aims for our project were as follows. We were trying to understand what the variations in the frequency and type of drug use were across different minority ethnic communities. So this was around prevalence, what is going on in terms of prevalence in the first instance. Thereafter, what are the various drivers of drug use amongst minority ethnic communities in terms of social drivers and other drivers as well. And then also, most importantly, what are the barriers and facilitators to support and treatment? In particular, we were interested in culturally sensitive care, in treatment and support, but cultural factors that may bear for those who use substances and are wanting to access support and treatment. The focus of the research was on non-opiate and cannabis drug use specifically. I'll hand over to Emily to talk you through what our project actually involved in and the various strands we worked through.
Thanks, Priya. So this was a mixed methods project which brought together findings from a number of work strands. So the first thing that we did was a review of pre-existing literature in the field to give us a bit of a better understanding about what was already known about the topic. So this involved us doing some searches on an academic database and also looking at websites of organisations or groups that we knew had done work in the field. So one example of that is the UK Drug Policy Commission. We included 25 relevant papers in this review that gave us a bit of background, both in terms of kind of statistics around drug use and also some kind of previous qualitative work that we'd found that captured some experiences of people with lived experience. And then to try and get a bit of a sort of overall picture of drug use, we looked at data from two national cross-sectional surveys. So we looked at the Adult Psychiatric Morbidity Survey, which focuses on mental health and well-being and is conducted roughly every 7 years. We used a combined data set for that 2007 and 2014, just because the sample sizes when we were looking at things like ethnicity and different types of drug use were very small in certain areas. We also did some analysis of the crime survey for England and Wales, and we used the 2019-2020 data for that. The crime survey is an annual survey that asks members of the public about their experiences of crime over the past 12 months, and drug use is one of the things captured as part of that. Then we kind of moved on to our big sort of qualitative part of the project, so our in-depth interviews, and we did 24 interviews with people from different minority ethnic communities who had self-identified as having experienced problems with drug use. This included people who had and hadn't support treatment, so we got sort of a variety of experiences. I think it's important to say here that we were really conscious that there was going to be such a range of experiences, you know, within kind of any community or group of people. We were really keen to try and understand how kind of different circumstances in people's lives, be it kind of ethnicity, religion, gender, kind of migration background, could all kind of come together and influence drug use. So we were also kind of conscious that there might be wider factors like sexuality that might impact experiences of discrimination or stigmatization. So when kind of thinking about sort of pathways to drug use and experiences of support and treatment, we wanted to try and capture that as much as possible. While we knew that would never be completely possible within sort of 24 interviews, we did try and sort of seek as much diversity across our sample as possible, looking at things like the types of drugs that people had used, ethnic backgrounds and age. There were still some limitations in terms of who we spoke to. For example, I think in the end we were able to reach more men than women, and sort of cannabis was a very prominent drug used among the samples. So it kind of wasn't perfect, but we were sort of trying to get as much sort of diversity of experience there as possible. We recruited people primarily through gatekeepers, so services that we worked with, who were so helpful to us in kind of helping us to publicize the research. And we also recruited some people through social media. We then also conducted 14 interviews with professionals involved in the design and delivery of treatment and support services. And this included academic subject specialists, community leaders, and treatment providers, including some people who kind of specifically led on culturally specific services or provided targeted support to particular communities. So those were our methods. I will pass on.
Thank you, Emily. Okay, so we are now going to explore the main findings and also our recommendations. I just would like, and we can start with the data from the secondary data analysis. But before we start, I would just like to describe the brief disclaimer, just because I think it's really important, especially with data we had to work with. So in our analysis of the APMS and CSCW datasets, it was necessary to collapse ethnic groups to ensure consistency, and due to small case sizes, this enabled a less detailed and less nuanced analysis of differences between ethnic groups, but I think it's important to explain that. So we weren't able to observe all the to study in details all the differences between groups because of this reason. It also must be said that figures may be affected by underreporting. So what happens is that while most of the sample completed the module on drug use for the CSCW, all minority ethnic groups were significantly more likely to refuse to answer these questions compared to the white British population. So this may also have introduced a bias in the data. And also just one last thing, I think it's really important that we do not consider these data as the description of stereotypes and on the basis of ethnicity. These figures should be considered just like an overall picture of drug use and not like a detailed description of each minority ethnic group. So first of all, survey data from both datasets showed that the numbers of people from minority ethnic groups who have used drugs vary when comparing minority ethnic groups to the white British population. From the CSCW, it emerged that prevalence of past year drug use was highest among the mixed other ethnic populations. While from the APMS, it emerged that prevalence of past-year drug use was found to be highest among the Black ethnic populations. Both datasets showed that prevalence of past-year drug use was lowest among the Asian community population. There was also variation in the numbers of people who have experienced drug dependence and the types of drugs that they use. Although cannabis was the most used across the whole sample, followed by cocaine and ecstasy. Despite all these differences, I think it's really important to point out that from a theoretical standpoint, ethnicity itself does not cause an increased or decreased prevalence of drug use. So what we decided to do was to look at the likelihood of past-year drug use by ethnicity when controlled by factors such as age, education, level of employment, the index of multiple deprivation, and so on. So different factors. When then we run these models, what emerged was that the Black and mixed or other ethnic groups were no longer significantly different from the white British group in terms of past-year drug use. So there were other factors that were actually intervening in determining the prevalence of drug use during the past year. Age was one of the main predictors. It was one of the strongest predictors of past-year drug use. And essentially age explains some of the differences in likelihood of past-year drug use between minority ethnic groups and the white British majority. Deprivation and poverty was also one of the strongest predictors. This explained some of the difference in likelihood of past-year drug use, especially comparing the Black group with the white British group. So what we tried to do, we, as mentioned, we tried to look at different factors determining drug use and also how this may affect different people in different ways. And as I said, this is like the general picture, but we also decided to go more in depth. And for this reason, we interviewed people with past experience of problematic drug use and also professional stakeholders. And so what happened was that from the interviews, we were able to determine a few really important themes that were common to several participants. There are several themes in the report, but we have decided to just to present three of the main themes here on this slide. So here you can see social influences and resources and access. And in the next slide, we are going to talk about mental health. So about social influences. So some people with experience of drug use felt that spending time with peers who use drugs as teenagers led them to first start using substances. Some spoke about their desire to fit in. You may notice from this slide that we are not using the expression peer pressure, because we decided to use the language used by the interviewees, and none of them talked about peer pressure. None of them talked about being actively pressured by their peers to start using drugs. But despite this, some of them mentioned how they felt this desire to fit in, this desire to be part of the group. In some cases, as mentioned, we used an intersectional approach. So we also tried to understand how other factors apart from ethnicity were at work when determining drug use. And for example, one of these was gender. In terms of pressure, what we noticed was the how some people explained that using drugs was seen as something linked to be a real man, to be something linked to masculinity, and so for them it was important to prove that they were real men, and so they were that's why they were using drugs. But in general, apart from this desire to fit in, one other thing that we noticed was the differences in people who were from, who had the experience of being in groups where their peers were mainly or exclusively white British people. In these cases, some people explained how being in this group was for them a chance to explore the use of substances that were not accepted within their own communities. So it was just a chance to explore other experiences, including that of using drugs. The other really important topic within the theme of social influences is the role of cultural acceptance or non-acceptance of substances. In this case, there is a complex relationship between the two. So in some cases, we found people who explained how the fact that the specific substance was more accepted than others within their community just like drove them towards that substance instead of the others. And in other cases, the non-acceptance of the substance was the reason why they decided not to use it. But then we also found people who explained how the non-acceptance of of specific substances within their community or within their family, so particularly negative views of these substances just was for them just like a further reason to try them. So it just ignited their curiosity. They just wanted to know more about that, and that they describe it like one of their main drivers. So the next theme is resources and access. In terms of availability of resources that can drive drug use, again, we were presented with a complex relationship. As mentioned before, deprivation emerges as one of the as something that is usually linked to drug use. But from the interviews, the relationship wasn't just in one direction. So what we found from from our research was that some people use drugs to cope with stress and depression deriving from them being unemployed or from them experiencing extreme poverty. But at the same time, there were people saying that not having money was for them a reason to reduce or stop using drugs. Or just using them like in social context when they were offered by friends. But at the same time, for others instead, finding employment or having more available, more disposable income was for them a reason to start using drugs even more, because they just had more access to drugs. Another important topic within this theme is the how easy to access drugs are in the area where where people grew up or where they live. So what happens was that we found people just explaining that in some cases drugs were just so widespread, so easy to find around them, that it was just everywhere, essentially. One participant even said something like, buying drugs, it's in my area, it's easier to call in for a Uber or ordering food on delivery. So just to explain how easy for him was to find drugs in his area. With regard to access, what we also found was the impact of policy on access, and essentially the example here on the screen is the cat ban of 2014. What we found was that after the ban, it was way more difficult to find fresh cat, and people using it at the time they just decided not to use it, because the dried one is not as good as the fresh one. But what emerged was that the cultural importance of cat, especially during gatherings to relax and enjoy a social gathering, was culturally really important. And for this reason, stopping using cat wasn't just like stopping using any substances at all, but they were just pushed towards other substances. For the people we interviewed, these substances were alcohol and nitrous oxide mainly, but it may be other substances as well. So this could be considered like a consequence of reducing access to certain substances. Then moving to our next theme, mental health. In this, mental health. So again, here we found a really complex relationship between mental health and drug use. First of all, we found from the analysis of from the secondary data analysis, it emerged that there is a relationship between mental health and drug use. So people who reported having mental health issues, they also reported having a higher prevalence of drug use in the past year, and this was true for all ethnic communities, all ethnic groups, so including the white British one. But again, in this case, it's not possible to establish like a causational relationship. So it may be not one the cause of the other one. And that's also where the interviews with participants and stakeholders are really useful. So and as I said, the relationship is really complex. First of all, participants discussed how using drugs was a way to cope with stress, anxiety, trauma, depression, as mentioned before. These issues may have been caused by recent changes, so like being unemployed or financial issues, or from past experiences. So, for example, child sexual abuse. And so they explained how, for them, starting using drugs or increasing the use of drugs was just a way to cope with all of this. But then what emerged was also that there were different layers. In some cases, the mental health issues were not just from general issues, but from issues that are like more specific to minority ethnic communities, and namely isolation, discrimination, or social exclusion deriving from racism, and we also observed the intersecting of different problems and different power structures. So, for example, for a gay man that we interviewed, they were experiencing isolation and discrimination and social exclusion because part of the a specific minority, ethnic minority, but then they were also experiencing discrimination and social exclusion from within their own community or from their family because of their sexual orientation. Then for them, using drugs, it was a way to cope with their situation, but this actually added an extra layer of stress because at that point they also needed to hid from their family and their community their drug use because all this was also stigmatized. So there was in the end, using drugs for them was a way to cope with all of this, and it just compounded on the existing situation. And this is essentially just the last point. So some participants felt that drug use actually impacted their mental health. Some people, as the person I just described, felt that their mental health that was already deteriorating just worsened because of the use of drugs and especially because of the stigma linked to it. But some other people also explained how using drugs just made some mental health issues emerge, mental health issues that they didn't have before, like paranoia and psychosis and other issues like that. So as mentioned before, and just to conclude, the relationship between mental health and drug use is really complex, but there is a very strong relationship between the two things. And now I would just like I'm just going to move to the next slide and leave it to Phoebe to talk to us about barriers to the main barriers to support and treatment, and then recommendations. Thank you.
Thanks, Crescenzo. So our research found that minority ethnic groups face a number of specific barriers to accessing and engaging with treatment and support services. So firstly, stigma, shame, and fear of judgment are barriers that contribute to some minority ethnic people concealing their drug use, which can then prevent them from seeking help. So for some, the stigma is related to cultural or religious attitudes to drug taking, leading to fears of being judged, isolated, or ostracized by their community if their drug use becomes known. And we found some evidence to suggest that stigma and shame are particularly a barrier for minority ethnic women. We also found that there was a lack of awareness of the available drug use services. Many of the people we spoke to did not know where to look for help, and it was felt that first-generation immigrants were more likely to face this barrier due to a lack of familiarity with navigating the UK healthcare system. Stakeholders also cited a lack of resources that limits the extent to which they can do outreach work and further publicise their services in different communities. Language barriers also play a role in limiting knowledge about available services, as literature about support is not always available in a variety of languages. Interpreters are not always available at services, and even when they are not always felt to be effective, limiting the extent to which some minority ethnic service users can successfully engage in treatment. We found that there was a significant lack of trust in services. For some people, this was due to previous bad experiences that themselves or someone that they know had had at treatment services, or just in the healthcare system more broadly. This included experiences of racism or feeling misunderstood. And other people had concerns over the confidentiality of the service. While no one that we spoke to had experienced a breach in confidentiality, it was a significant fear that such a breach could lead to community members finding out, linking back to sort of fears around stigma and judgment, or that law enforcement or social services would be informed about their drug use. And this was felt to particularly be a concern for asylum seekers and mothers. There was also a lack of trust that the service one might receive would be appropriate for their needs and be culturally informed. For some people, this was related to the perceived lack of diversity amongst staff members at treatment centres, and prevented some people from accessing services. Relatedly, when people did access services, there was felt to be a lack of cultural competency. For example, some people with experience of drug use would feel more comfortable talking to someone from a similar background to them, both in terms of their ethnicity or religion, as well as having lived experience of drug use. Some minority ethnic women would prefer to speak to other women and could be deterred by male-dominated services. And services are not always well equipped to cater to the preferences of service users in this regard. A barrier faced by some was a lack of awareness about the impacts of their drug use, which led to difficulty in perceiving their drug use as problematic, and so potentially something that they should seek help for. Cannabis use in particular was considered very normalized in society, particularly for the Black Caribbean participants who we spoke to, who felt that cannabis use was accepted in their community and not viewed as something that you might need to access support for. This normalization acts as a barrier to help seeking, with stakeholders we spoke to highlighting that help might only be sought once a crisis point is reached. Finally, there were some financial barriers. While there seems to be awareness among different communities that free support is available, participants were wary about the quality of free services and thought that they might have to go private to receive high quality care. The price of private services was viewed as particularly prohibitive to minority ethnic people, and in particular young minority ethnic people. Can I have the next slide, please, Crescenzo? Thank you. So we formulated a number of recommendations for service provision and future research based on the findings, particularly around barriers from all of the work strands. So the first recommendation concerns improving knowledge and trust in support and treatment services. To improve knowledge about services, materials need to be made available in a variety of languages and distributed at places where minority ethnic people gather, for example, community centres and places of worship. Outreach work into different communities is also an effective way to publicise services further. Ideally, this would involve partnership work with organisations already integrated into communities who are doing effective work and have strong working relationships with community representatives. And this could also involve working with GPs who are found to play an important role as a first point of contact to ensure that they're well equipped to signpost to appropriate services. Fostering relationships with respected community or religious representatives is also an important way to increase trust in services and address misconceptions and fears of stigma. Services also need to ensure that they're offering a culturally appropriate service. As part of this, the lived experience and diversity of staff and volunteers needs to be considered, as some people work most effectively with someone who has common experiences to them. Ideally, service users would have as much choice and flexibility around their support as possible to ensure that their cultural needs are met. This reflects the fact that needs and preferences will vary between individuals across and within ethnic groups. This will require resources to ensure that staff are sufficiently trained to understand the needs of their local community and are able to deliver sensitive, tailored support. A key area of focus should be partnership working with existing organisations, recognising that one service is not able to cater to all needs and situations, and should make use of the expertise and experiences of other services in order to deliver the most appropriate care. Have the next slide, please. So there's a need for a holistic approach to service provision that recognises that drug use issues do not exist in a vacuum and often co-occur alongside issues relating to mental health, physical health, housing and employment. So for drug treatment services to be most impactful and most helpful, there needs to be wraparound support which addresses these other challenges alongside drug use. This may involve multiple services working together. It may also be beneficial to draw on learning in other areas of healthcare in order to build trust and implement culturally appropriate approaches. Due to the additional barriers that minority ethnic people face in accessing drug use services, there is then an increased importance placed upon these services being as easy to access and responsive as possible when people do reach out to them. This can include a consideration of opening times, waiting times for appointments, flexibility of appointment times, and the location and delivery mode of the support. In terms of recommendations for future research, our research has highlighted gaps around the experiences of affected others, the loved ones of people who use drugs, and examples of good practice for early intervention and aftercare. This project has also highlighted how demographic and psychosocial factors intersect and inform experiences of drug use. These experiences should be explored further in future research, in particular with people from minority ethnic groups who face specific intersecting challenges, for example, related to asylum status or sexual orientation. Our research also demonstrates the importance of not making generalizations on the basis of ethnicity or seeking to explore experiences of ethnicity in isolation without consideration of broader factors such as age, gender, deprivation, or migration history. Next slide, please, Crescenzo. And then I'll hand back to Emily and Priya.
Thanks so much, Crescenzo, Phoebe, Emily. We're just coming up towards the end of the presentation now, but just to finish off, just wanted to explain that, as you can see, stakeholder engagement was really important for us. So not only was it important for us to conduct the in-depth interviews with those with the lived experience or communities that we're specifically interested in, we wanted to engage with clinicians and those who work in support services and treatment services. So rather than collecting data from them, as we had done with those with the lived experience, what we did was engage with a number of people who are kind of wider stakeholders, but we also wanted to provide the opportunity to clinicians and others who work in these wider kind of support services and treatment services type roles to feed into our interpretation of our results and our findings and kind of what the recommendations we were going to be putting forward. And so we did hold that stakeholder workshop. It was a great event. And we did have some interesting discussions. There's a question in the Q&A which we can answer a bit more fully shortly, but it's around peer pressure and the role of peer pressure as a driver for substance use. And this was one of the things that we discussed in the stakeholder workshop, because various clinicians serving different types of communities in different parts of England had different anecdotal evidence around kind of what the role of peer pressure is and that kind of thing. So we had this stakeholder workshop and it was incredibly valuable, but we got some really positive feedback saying thank you for kind of including us in your study in this way, giving us an opportunity to kind of contribute and input into your interpretation of the findings and subsequent recommendations. Pleased to say that the final report from this project was published last month, so you can go onto the NatCen website and download it. And if you have any questions, please you can ping any one of the authors who are listed there. But there were a number of people that we have to say thank you to in terms of making the project possible. I mean, I mentioned the funder at the beginning of the presentation, but there were a number of gatekeeper organisations, community leaders who were really instrumental in us being able to conduct this work and generate awareness about the study and access participants and that kind of thing. So we just want to say thank you to them as well. In terms of what the next steps are, well, we've already been given some anecdotal feedback on the project and on the report, saying that this is the first time in a long time that up-to-date data, both survey data and in-depth qualitative data, have been kind of brought together in such a comprehensive way, specifically to do with these with the research aims that I presented at the beginning of the presentation around minority ethnic communities and barriers to treatment, and before barriers, understanding actually what the prevalence is. So whilst it's been well received, and we're really happy that it's been well received in that way so far, there are a number of gaps that we would love to continue on kind of exploring and studying moving forward. First of all, we'd really like to understand the long-term journeys with substance use, and there is scope to have a better understanding of the role that early intervention can have, but also aftercare. Once you've gone through the initial kind of treatment and support plan that you might be working through, if you're a user, and what happens thereafter, and how can you continue to access the support you need as your frequency of substance use changes over time, for example. We also have conducted research on gambling, for example, and in other fields related to substance use. There's more data available around what the impact is on affected others. So, for example, carers and family members and friends of those who use, who are, for example, engaged in problem gambling. But for substance use, that there is still a gap around that, specifically around minority ethnic communities. So there's more work to be done in that area. And this study specifically focused on England. So, speaking to colleagues who work in support services in Scotland, for example, and in other parts of the UK, there is scope to do to conduct some parallel studies in the different UK contexts to understand, what is happening there, what are the patterns around prevalence, and what are the localized kind of issues around barriers to treatment and support. Finally, in terms of service providers, I mentioned that stakeholder workshop earlier. We could do some more in-depth research around, what do service providers need to be in place in order to implement some of the recommendations to actually be able to provide the care and the support that they know those with substance use issues would like to have. What conditions do they need to be able to deliver on that? So there's just a few kind of evidence gaps there that we would love to kind of work on moving forward. But that brings us to the end of the presentation. Thank you to my fellow team members and presenters here. We've really enjoyed being able to have this opportunity to talk to you about our project in this level of detail. Thank you to all of you on the webinar for your patience while we talked you through all of that. The next stage of the webinar is for us to kind of address some of your questions, and thank you to some of you. I've already been having a look at some of the questions that are coming through in the Q&A, and we will try and do our very best to answer your questions between us. So we're not likely to be able to get through all of them, but as I say, we'll do our best, and we're happy to kind of see that there's an ongoing discussion and debate around this. So the first question is it possible that results would vary or differ significantly if other drugs had been the subject of this study? Obviously, opiates in particular. This is really, thank you for your question, and this is a really important question. There may well be differences in terms of the up-to-date information around specific different types of substances. So I can't really comment on that. As I said, there are a number, as I said in the Q&A chat, there was another question in there that I answered around why is it that our study was focused on non-opiates and cannabis. And this was a specific area of interest by our funder, but also an area that was identified as having a specific evidence gap that really needed addressing. So in terms of prevalence issues and what we would find around prevalence, I wouldn't want to sit here and guess what the results might show. However, what I might say is, as I said, we've done research around problem gambling, substance use, tobacco use as well. There are, some of what Phoebe discussed around stigma and shame and those sorts of things seem to read across that kind of, these areas. So there may well be some, I wouldn't be surprised if the results did show kind of the role of stigma and shame acting as a barrier to accessing treatment and support. But I don't know if any of my team members want to come in on that question at all.
Yeah, I'd agree, Priya. I think in particular with regards to kind of accessing treatment and support, some of the barriers that we heard about did feel like things that might be experienced across sort of different types of drug experiences, whether kind of services have sort of appropriate kind of cultural supports and kind of diversity and sort of in terms of recommendations as well, thinking about things like outreach programs, all sort of feels like it could be very relevant across different experiences as well.
And just one thing, with regard to opiates and crack cocaine, and I think alcohol as well, there is currently a parallel study underway, conducted, I think, by the University of York. So these two studies are, in a way, we didn't work together, but they are in a way, at least in terms of aims, complementary. And yeah, I agree with Emily. There are definitely some of our findings are definitely going to be shared by other researchers on other substances, because they are like more in general, they regard more in general things like stigma, for example, which is common to almost any kind of drug use. So just to give an example, And there are also some more recent studies that were conducted recently on more specific subjects, such as alcohol in South Asian in the South Asian community, especially for women, with the focus on women. And I've checked some of the findings, and actually there are a lot of points of contact with our findings. So there are definitely things in common between different uses of substances.
Thank you, Emily, Crescenzo, and I guess the other thing there is about polydrug use as well, isn't it? So that's another thing as well. Okay, moving on to the next question. This question is from Hugh. How useful is social media as a tool to recruiting or collecting data for research on sensitive topics like this one? What is needed to use social media successfully? I'll have a go at talking about this, and then again, if my team members want to come in. So we did use social media, as mentioned in the presentation, to try and recruit participants into the study. It did actually help us engage members of the wider community, but also for those who was interested in participating and eligible to participate in terms of who we were looking to speak to. So we kind of had a social media plan, communication plan around that piece. The other thing is we also worked quite a lot with, like, for example, community radio, community press, that kind of specifically serve the communities of interest. And some of these are pre-existing relationships that I have and others at NatCen have. So we were able to build on that. And again, they're important kind of gatekeepers and stakeholders in this work and in this study. And they did support us in kind of more broadly generating awareness around the study and helping us kind of, bridge the gap between us and participants. I don't know if anyone else wants to come in on that one.
Yeah, about the use of social media, there are obviously limitations, and what we did for this study, but actually I would say probably has been a strategy in our team for some time now. We tend to use like more than one approach to recruitment. So it's not just going to be social media in most cases, but it's going to be social media, gatekeepers, and a number of other approaches. There are limitations in the use of social media for recruitment. The first example that comes to mind is if you post your ad on Facebook, the average age of the typical Facebook user is now becoming just like older and older with time. So there are less and less young people on Facebook. This means that you are just going to have your ad seen just by people or in specific age brackets. And this could be a limitation in a way. So there are pros and cons, and obviously there are some subjects that are more appropriate for social media than others. So and for this one, just to give you another example, for this project, recruiting on Facebook, we also had issues. And our comms team was great with this, but they had issues with publishing the first advert because of specific words. It meant that Facebook had to check the ad like manually, so it couldn't be approved automatically because of the presence of drug or cannabis and so on within the text of the advert. So there are like different kind of limitations, also practical ones.
Thank you, Crescenzo. Moving on to another question. Who's going to be interpreting the results and likely to be using it for creating policy? I like this question. So this was one of a few projects that were commissioned by the Department for Health and NIHR, as I said, and with support from the London School of Hygiene off the back of the 10-year drug strategy. So that's the kind of policy context of it. And these projects were designed and conceptualized as being key to informing policy as the 10-year drug strategy is being rolled out. And so we're confident that our reports will fall into the right hands and onto the right desks that can make a difference to, at least, as I say, informing policy. And as your question kind of asks, and in addition to that, it has been submitted in terms of calls for evidence by kind of key bodies and advisory groups that have approached us directly. And some of these advisory groups and bodies are kind of very close to governments and the whole system's approach to substance use, that are looking at substance use from a health perspective, from a crime perspective, from a justice perspective, and a social cohesion perspective as well. So again, where we've been able to submit the report as part of wider evidence to kind of inform the work of these bodies and associations, it's been that's promising, and we think that's very positive that we're able to kind of feed into the work that's being done around that. I don't know if my team members want to come in on that. No? Okay, brilliant. Hopefully that answers your question. So let's see. How did you analyze the interviews? So that's quite nice to have a methodological question. I'm trying to mix it up here. Who would like to take that one? I'm thinking, oh, Emily, you want to have a first pass?
Yeah, I can talk a little bit about that. There is, I know someone else in the questions asked for the link for the report, so we'll circulate everything again, I think, after this webinar. As well as the main report, there's also an appendix which has a lot more detail in about our methods, including our topic guide for the interviews for anyone who'd be interested, and some more detail on analysis. But essentially, we used a kind of framework method whereby the interviews were written up into matrices, which kind of allowed us to group findings around our research questions and draw out themes. When we were analysing our interviews, we also drew on the theoretical domains framework, behavioural framework, and also kind of intersectionality theory, just to kind of help us understand and sort of group findings, look at different behaviours, and what sorts of things might particularly inform behavioural changes, be that kind of decisions to seek support or decisions to kind of increase or decrease drug use. So yeah, that we sort of use this overall framework with some kind of theoretical underpinning to it as well. I don't know if any of the members of the team have anything to add on that.
I think you already said everything. Just adding that we decided for the report to be like something for a general public and not just a specialist publication. We decided to limit the amount of references to the TDF and how much we used in the description of the findings. But it was essential also to design the fieldwork material, especially the topic guide, together with the intersectional approach. But as Emily said, there are more details in the appendices on the methodology, and obviously we are always happy to respond to your questions if you want to get in contact.
Thank you. both. On to another question now. Did this research take place in a specific geographical location? And if so, do you think this affected responses as differing areas may have different understanding or acceptance on drugs? This is a really lovely question. Thank you very much for submitting that, for posting that question. So as we said, this study was focused on England, but what we try to do in qualitative research is to kind of explore a range of response and trying to gather different perspectives. And as you quite rightly put in your question, different areas may have different understanding and acceptance on drugs, but they might also have a different landscape in terms of the treatment and support that's actually available in the local area, that's sensitive to different cultural needs, for example. So we did have some geographical spread. We did interview those with lived experience from different parts of the country. We didn't cover all the areas, of course, and there are indeed some gaps in the sample there, but we're confident enough that we were able to have that kind of range of response that kind of gave us some wider kind of understanding of how challenges might be different in different local contexts. And as we were working with some, gatekeepers, some of them work, some of these community organizations serve their local area and serve the minority ethnic communities within their local area on not only kind of substance use support, but as kind of Phoebe said, there's a lot going on here. There's things around kind of access to health services, housing, employment. And so some of these community organizations actually provide very localized and specific and tailored support to some communities and communities in their local areas. And so that gave us a good kind of more nuanced understanding of the environment within which people might face barriers to treatment and support, and how services kind of respond to these. But yes, we did have some geographical spread across England. It wasn't just London. It wasn't kind of the areas that are often cited as the main places where you'd go to conduct this type of research, because they've got high population of these communities within their areas. I don't know if the team want to kind of top up what I said there, kind of add to anything that I said there.
I was just going to reflect just in terms of location that I think often when we kind of spoke to participants and they were telling us about their experiences, they were talking about kind of their local area as very sort of hyper local. So it was kind of comments about their town or, a state, or kind of like the school that they'd been to, or something like that. So it was often, I think we definitely had sort of themes coming through on the impact of, where people live and kind of local area. And yeah, often it was extremely local. So yeah, as they've said, there's kind of potential for that to be different, even with sort of within a really kind of small area.
And just one last thing, actually, following from Emily, there were also a few cases where people were talking about their experience in the area where they grew up, or where they lived until some time before the interview. So in some cases, these people were from areas were calling, because we all use the different approaches to interviews. So there were remote interviews and also face-to-face interviews. And remote interviews, people may have contacted us from some areas, say, I don't know, Brighton, but they said they grew up in Liverpool, for example. So there was also this. So and it also kind of links to the fact that people life experiences are not linear, and also these changes of areas were in some cases among the determinants in their drug use.
Thank you. A question, one of the kind of questions that we've had is, how do you feel about basing your work in 14 interviews? Do these offer an adequate sample size, in your opinion? This is a really good question. It kind of links back to what I was saying in response to the last question. How big is a qualitative sample? This is an age-old debate, and it's still ongoing. As I said, in an ideal world, you'd keep, you're looking for a range of response here. This is not statistical representation we're after here. You're looking for a range of response, and in an ideal world, you'd keep going until you hit data saturation. Okay, so that means that no new themes are kind of coming up or emerging in your data, and you feel like you've covered all the bases in kind of what you're looking for in terms of addressing your research questions. Now, these are hard to reach groups. These are groups who are not necessarily that engaged with their local health services. There are, for those who are on visas or on specific types of, immigration status that they have, there is a fear of participating in this type of research, for example, or even that. And in fact, that was one of the things that came through, is that that's another reason why people might be kind of apprehensive about accessing the support and treatment that they need. And so these are hard to reach groups. Something we were getting from the community leaders and the gatekeepers is the gatekeepers themselves have faced a lot of research burden in coming years, because lots of people want to do research on these communities for various different studies. And there's a feeling of, hang on, the health system as it is not really meeting our requirements anyway. There are huge gaps in meeting our needs. On top of that, you're coming to us when we have very little resource to be able to serve the communities in the way that we're trying to. You're asking for us to provide additional support to you to be able to bridge the gap between you and participants. There's a lot there to unpack. So recruitment was incredibly challenging for us, and we were out in the field trying to gain access to participants and engage with them for a long time, for longer than we'd actually originally timetabled and anticipated to do so. So there's a few different things there, and we have to sort of respect the fact that there's research burden faced by both the gatekeepers and the participants themselves. There's a lack of trust for some sections of the community around health services, or even this type of research. What are you going to do with my data? Why do you want it? Are you just going to use it against me rather than actually make any recommendations that could help people like me? So actually, in the end, and we spoke we kept in touch with the Department for Health and our client, the team we were working with there, at regular intervals. We tried so many different ways to try to recruit. We recruited through the gatekeepers, through our existing contacts, through social media, through community press as well. And this is what we landed up with. In the end, we felt that we had enough to be able to address our research questions. But as we were clear, there are still gaps. There are sections of the community we weren't able to collect stories from, or hear stories from, collect data from and hear stories from. So those gaps remain. But we are confident that what we've done is the best that we could have done within the time and resource available for the study, and for us to be able to, along with the survey data analysis and the other method, or the scoping review we conducted, and all these things, and we triangulated all that data together to try to address our research aims. And it's not just a work strand on its own, but it's all of that put together for us to kind of understand what the bigger picture is. So yes, we would have loved to have more participants and to have heard more stories, and to have closed some of those other gaps in the sample. But by and large, we are happy in the end with what we were able to achieve. Emily, Crescenzo, Phoebe, do you think that?
Yeah, could I just clarify? So we did 14 interviews with professional stakeholders, but we did 24 interviews with people with experience of drug use. So there were 38 interviews total. And yeah, like you said, Priya, our findings aren't just based on the qualitative interviews, but there were multiple work strands, including a literature review that looked at sort of 25 papers that had already been published. And obviously a lot of those were based on interview findings as well. So yeah, I think once we took it all together, we did reach data saturation to quite a large extent. But yeah, obviously we weren't able to speak to every different type of minority ethnic person in England. So yeah, there will be gaps.
Thank you for clarifying that one, Phoebe. I forget that everyone is not as close to the data as we are and the work that we do. But either way, there were these are kind of standard sizes for whole samples, aren't they, of stakeholders and those with lived experience as well. Okay. There was a question around, did you manage to get a good balance amongst your participants of people who are currently in treatment or have been in the past, and those who use drugs but haven't accessed treatment? In the end, we broadened out our sample criteria actually to cover both, but I'll leave it to the rest of the team to actually take this question.
Yeah, so we had quite an even split, I think, in the end between people who had access services and people who hadn't. And then there was quite a lot of diversity, like sort of within that split. So within the types of treatment access, there was quite a broad range from sort of residential rehab to kind of more local based community services. And then amongst the people who hadn't accessed treatment, there was diversity amongst those who had considered accessing treatment and thought they would benefit from doing so, but who faced significant barriers to doing that, and people who didn't think that they would benefit from accessing treatment for multiple different reasons. So yeah, there was quite a broad range in terms of treatment experiences.
Thank you, Phoebe. There's a comment here. I don't know any support workers, drug workers, practitioners, etc., that are from the BME community, and I'm quite involved in the service user involvement in my area. So I know a lot of the workers, and none of them are BME. That makes all the difference, I think, when it comes to the willingness to engage with people who think and can relate to you. Thank you for that comment. Absolutely, there are services. I'm no doubt that actually in your local area, I completely believe what you're saying, in that those that are the support workers don't necessarily reflect the characteristics of the wider population that they're trying to serve. And there's a tension between the stigma piece and shame of kind of engaging with someone from a similar background to you, but then there is also that shared understanding as well. So some of that tension was there in our data too, but some of the stakeholders we spoke to and some of the clinicians we spoke to were from minority ethnic communities, not all, but some of them were, and there was a feeling that those with, you know, in some instances, this is like, you know, it's very specific and nuanced, but for some people that did make a difference in being able to open up about their needs and their journey with substance use, and what their next steps might be. Emily, Crescenzo, I don't know if you have anything else. Phoebe, don't know if you've got anything else you'd like to say on the back of that.
Just to add to what you said, I think that came out as a really strong theme, the kind of importance of people having similar experiences to the sort of staff members at treatment centres. It was definitely very important for not all of people we spoke to, but quite a lot of people we spoke to, that there would be, I guess, a kind of shared understanding, whether that was in terms of kind of cultural or ethnic background or in terms of lived experience of drug use. And we did speak to, like you said, some professionals working in the area who were from minority ethnicities themselves, and some of them had sort of, I guess, organizational data based on monitoring data to suggest that they had had more access engaging minority ethnic service users than white staff members at their organization. So yeah, just to say that I think that is a really important theme from our report.
Thanks, Phoebe. We've had a question come in here, which might take some unpicking, but it's an interesting one. What about those who are viewed as an ethnic minority because they are visibly not white British, but they have been raised in a predominantly white environment? These individuals may present on paper as a white British person may in terms of engagement with health professionals, etc., but will still face barriers due to their appearance, despite there being no marked impact on their lives from cultural issues, etc. Thinking about those who are mixed race, would these individuals skew this data? Well, there's a lot to unpick in that question. We had some participants who identified as being dual heritage and as mixed race, as per the terminology used in this question here, both in the qual data as well as in the survey data analysis as well. I think I mean, I'll do a start for 10 and see what the rest of the team think. There's just so much to pick there, isn't there? And it kind of comes back to treating somebody as an individual, and not stereotyping what their needs might be and what their experiences might be, because there's so much that lies beneath that. So there could be migration history. There could be, there could be people who've come direct from another country. There could be people who are twice or thrice migrants. We mentioned this point about language barriers not really being there so much for the first generation who may have been born and brought up in England, but it might be more for those who are older or more recent migrants. So there's a lot there around really understanding who the person is in the first instance before you try to meet their needs. But again, I'll see what my team members think.
Thank you. And yeah, it is a really interesting question, but as Priya said, we included the experience of a few people who were either like coming from dual heritage, or in some cases they were like from a minority ethnic group, that it's a visible one, but at the same time they grew up with mainly or exclusively white British peers, and yeah, there were some differences in these cases. There, as mentioned in the presentation, some differences were in terms of feeling like being part of an exclusively white British group of peers, being an occasion, a chance for exploring something that is not usually discussed or experienced within their own family, for example. And in other cases, and this was not in the slides, but it's in the report, there were issues in terms of identity. So, for example, people who were born in the UK, but from first generation parents, and what kind of consequences this had for their identity. So it is a really important point. There are differences, and probably one of the giveaways of the whole report is that the number of different approaches to drug use and treatment and support is almost comparable to a number of people we interviewed. So we interviewed 24 people who were with experience of problematic drug use, and there were 24 different experiences with some similarities, but also a lot of differences. So yeah.
I was just going to add one more reflection, which was that something that, again, I think was not on the slides, but is in the report, is that something that came through was about sort of people's broader feelings towards kind of healthcare services and support services being sort of informed by wider experiences of family and communities. So it may be that somebody is, as you say, kind of, I suppose, presents as a white person and may not feel that in their specific interactions with a healthcare professional, they feel stigmatized or whatever. But it was clear there was also views kind of coming from experiences of the family and kind of the wider community that could lead to sort of distrust or disliking of particular services.
Thank you. Thanks, Emily. We've got a question here about the cat ban. Apologies if I'm not pronouncing that correctly. The 2014 cat ban mentioned appears to give anecdotal evidence that drug use and availability is empirically linked. This would be a huge finding if rolled out across the whole of government drug policy, restrictions on drugs rather than licensing and provision, etc. How relevant is this anecdotal example? Well, that is a really interesting question, and there's a lot of discussion around that at the moment in the wider area around smoking, tobacco, vapes, for example. So I think the government have just said that they will end the sale of disposable vapes, for example. And we, myself and the team here, we worked on a project for NIHR looking at trends in tobacco use and how actually availability of tobacco in relation to changes in age restrictions, changes in advertising, and that kind of thing had an impact over time on take-up of smoking amongst young people and young adults and adults more generally. For that study, I mean, it's a few years old now, but we found that, yes, there seemed to be some sort of link, but it was difficult to pin that down completely to controls around advertising smoking, for example, and that it was also linked to kind of wider efforts and investment in resources for those who want to quit smoking, for example, and cessation services and that kind of thing. So there's quite a lot going there in terms of how much impact can access, advertising, and that sort of thing have. You know, how much difference can that make to actual prevalence and subsequent need for treatment and support. It's not an easy one to unpick, but a really, really interesting point to consider, I think. Again, team members, any thoughts?
Yeah, just that it is really interesting, and it would be great to have more not just evidence from a few interviews, but like more wider evidence on this. But yeah, it was just a few interviews, and this was the personal experience of interviewees and their opinion. So what they said was essentially, we just moved to different substances. But that was their experience. It may be that if we interviewed other people, they would have different experiences, like stopping using substances at all, or maybe for others, using other illegal drugs. It's difficult to say because it's just based on the lived experience of the people we interviewed.
Thanks, Crescenzo. Emily, did you want to add anything or no?
No.
Okay, it's fine. It's interesting you mentioned places of worship for those trying to access support. How important is this area in supporting addiction treatment and care? This is a really interesting question, and some of the community leaders, and thank you for your question, some of the community leaders, stakeholders, and kind of other key informants who we spoke to and engaged with during the course of this study are, you know, active members of their local place of worship, for example, or even networks of places of worship. And some of what came out around that is that it can be very important to kind of help break down stigma, to say that you are welcome here, that you're still very much part of our religious community, our cultural community, and support is available for you, and there's nothing to fear, kind of around that. Now, whether that works in practice or not, there seems to be a mixed bag in terms of how those people who need that treatment and support actually engage with that. You know, so some do engage with it and find it you know, it kind of removes a barrier in a way around that stigma and shame, but others are still concerned about actually being so close to the community, actually, and being so vulnerable with the community around their journey so far with substance use and their next steps. So that there is a mixed kind of picture there. But in terms of how important is this area in supporting addiction treatment and care, there seems to be something around breaking down the barriers from within communities, and how places of worship and local community centres and places of worship can and these kind of social groups can actually make a difference to kind of making it acceptable to at least talk about these things, that there is substance use going on in the community, but there is help available, that, you know, that these people are still part of our community and our families and our friendship groups, and that if more could be done from within the community to help break down those barriers, then more, the next steps could be taken forward towards kind of addressing those issues around stigma and other barriers to treatment and support. I don't know if other team members want to come in there.
I was just going to say that I suppose it goes back to your earlier point, Priya, about sort of treating, every person as an individual with different circumstances. And I think places of worship and kind of the role of religious leaders was something that came across from some people. There were also, though, other kind of examples mentioned of sort of that role of kind of people who are respected or kind of within the community. We had one or two people, I think, who spoke quite passionately about sort of the role of youth workers in their own experience as people that they had kind of looked up to and were sort of able to support them when they were kind of experiencing challenges with drug use. So yeah, I think it's about that sort of that community and respect and having those people on board, whoever they might be for the individual person.
Thanks, Emily. And I think one more thing I wanted to say is that, again, there was this mixed bag in terms of being mixed success. So we spoke to some stakeholders who were linked up with the local religious communities and places of worship, and they were kind of delivering abstinence-based support programs for those engaged in substance use, but also were wanting support in reducing the alcohol consumption or stopping it altogether. And there were advantages seen from the stakeholder perspectives around that, in terms of it's, a lot of this is charity based and not really funded, very well funded at all, or it's completely based on volunteer time. So in terms of actually paying for a venue and having access to a venue, the places of worship were offering these places for free. They were offering kind of teas, coffees, and sometimes meals for those who were attending, and that was seen as a great thing. But then there was also some on the other side of things, there were members of the community that, when there were breaks during these sessions where people who are attending these abstinence-based kind of support group meetings were then going outside to have to smoke, for example, and the members of the local temple community, for example, were not so happy about that, and were saying, actually, we've come here to pray, we didn't really need to see that. And so there were some tensions around that in terms of members of the local community local religious community and place linked to a specific place of worship, wanting to support these people and doing so through access to free venues and teas, coffees, and meals, but also that the wider community were not always happy about it, that they were being accommodated in this way. So yeah, lots to unpick, and again, not just a black and white. Some things work for some people, but that don't for others within the community, not so open to it. Was there any difference in perception of barriers to treatment between service users and service providers? I think Crescenzo is probably the best place to answer this.
Sorry, could you repeat the question?
Yeah. Was there any difference in perception of barriers to treatment between service users and service providers?
There were some differences described. It's difficult now to say because we described them in the report as like a main narrative. So it's difficult now to remember from the interviews which were the main differences between the two categories of participants. There was, from what I remember, there was definitely a from the point of view of service providers, they were insisting more on like specific barriers to, like, more organizational barriers, having the resources being well prepared, and having good outreach experiences, and this kind of more organizational points, while for people it was more like based on personal experience, so it varied way more. I don't know if, Phoebe, if you remember maybe better than me from the interviews.
Yeah, I think there was a lot of overlap.
Yeah.
Some differences I can think of are more around, particularly the concerns around confidentiality. Like that was such a huge concern and barrier for service users. Yeah, again, links back to things around stigma and shame and things like that. And that didn't get brought up as much by service providers, I guess, because from their perspective, to them, like obviously their services are confidential and they trust in their own processes that they've got in place around confidentiality. So yeah, I guess that was one difference, where that was a really strong barrier for service users that wasn't mentioned very much at all by service providers. But otherwise, yeah, there was a relative amount of overlap. And yeah, like Crescenzo said, the more, I guess, like processy or organizational barriers were mentioned by service providers that service users might not kind of be aware of as much.
Thank you both. I think we're coming close to time now. There was just one actually I wanted to cover off quickly, if we're able to. But where would you point drug and alcohol service providers and support services to access accredited cultural competency training? Good question. I'm afraid we don't have the answer for that. I have to say there was a lot around cultural competency that came out and cultural sensitivity, what is culturally appropriate in terms of providing support. And treatment plans and that kind of thing, but not there was no citation of a really good tool that could be used, or specific examples of best practice that are shared amongst practitioners and clinicians themselves, for example. And there's a lot of debate around, can it be used as a checklist? Can it, how effective can cultural competency training be on its own, or does it need to be part of a wider package of kind of training and development for service providers and support services? So that's kind of my reflection on it based on the studies. But I'll just give an opportunity to the rest of the team in case they wanted to come in on that.
I was just going to reflect that this was something that was mentioned during our stakeholder workshop as well, just in terms of the kind of what's next for organizations who read the report and think that they'd like to take on board some of these recommendations, and that is definitely something that we acknowledge and that we have acknowledged within the recommendations, is that to make changes and to do further work takes time and it takes resources, which needs to be supported. So yeah, not really an answer, but just acknowledging that.
Yeah, just to quickly add on to that, it obviously came out a lot that there's no one size fits all approach to cultural competency, and each service provider needs to be informed by the specifics of their area. So I think two things were recommended quite a lot with that, which was to be informed by local data and by the kind of community that you're aiming to serve, and then also the involvement of lived experience and sort of co-production in any processes to establish culturally competent approaches.
Thank you, team. Thank you all for attending the webinar today. I think we're going to have to draw it to a close now, but I think we managed to get through most of the questions. So thank you so much for attending. Really great to have you all here and to have you engaged in and interested in our work and wanting to learn more and kind of continuing the discussion and the debate around it with us now. Just to say again, the report is available on the NatCen website for you to download. It's free to download. And the webinar itself will be on the NatCen YouTube channel and on LinkedIn and the other kind of main social media channels. And again, a big thank you to not only our funders, but also everyone who participated, all of our research participants, all of the gatekeepers and community groups that engage with us along the way. It wouldn't have been possible without you. So thank you all for attending today, and we hope to continue this work and build on it. Thank you so much.